Discuss the etiology, clinical features, investigations, and management of ankylosing spondylitis. Ankylosing spondylitis is a chronic inflammatory disease of the axial skeleton characterized by the back pain, progressive stiffening, and fusion of spine. It has predilection for the sacroiliac joints and spine. Ankylosis refers to a fibrous or bony bridging of joints. In the spine, this includes bridging of one or more intervertebral discs. Etiology. Exact etiology is unknown. Genetic factors. Most patients are HLA-B27 positive. Close relatives of patients with AS, that is ankylosing spondylitis, have increased risk of developing AS. Infections. Increased fecal carriage of Klebsiella aerogenes occurs in patients with ankylosing spondylitis. Clinical features. It characteristically affects young adults with a peak age of onset between 20 to 30 years. Males are more commonly affected. Male is to female ratio is 3 is to 1. Articular features. Spine and lumbosacral joints are mainly involved. Insidious in onset of low back pain and stiffness. Pain and stiffness are worse in the morning and after inactivity and are relieved by movement. Lumbosacral area is usually the first and worst affected region, but rarely thoracic or cervical spine can get affected first. As the disease progresses, whole spine is affected. As the spine becomes progressively ankylosed, spinal rigidity and secondary osteoporosis predisposes to spinal fracture, presenting as acute severe, well localized pain. Secondary spinal cord compression is a rare complication. Examination shows restricted spinal mobility in all directions, pain on sacroiliac compression, and diminished chest expansion. Increased flexion of the neck, increased thoracic kyphosis, and loss of normal lumbar lordosis may lead to a stooped posture. Peripheral arthritis is seen in 30% of patients. Hips, knees, ankles, and shoulders are mainly involved. Peripheral arthritis may precede spinal involvement in 10% of cases. Extraarticular features. Enthesitis, that is inflammation at tendon and ligament insertion sites. Achilles tendon, iliac crest, and greater trochanter. Eye. Anti-Rheumatic conjunctivitis in 20% cases. Prostatitis in 80% men. CVS related aortic regurgitation, pericarditis, MVP. RS related atypical upper lobe pulmonary fibrosis. CNS related cervical myelopathy secondary to atlantoaxial dislocation. Cauda equina syndrome. Kidneys. IgA nephropathy secondary amyloidosis. GIT related mucosal ulcers. Investigations. ESR and CRP are usually elevated. Rheumatoid factor is negative or present in low titer. HLA-B27 is usually positive. Radiographs. Sacroiliac joint is usually first involved. X-ray of sacroiliac joint may show irregularity and loss of cortical margins, widening of joint spaces, sclerosis, narrowing and fusion. Lateral thoracolumbar spine X-ray may show anterior squaring of vertebrae due to erosion and sclerosis of the anterior corners, bridging syndesmophytes, ossification of the anterior longitudinal ligament, and facet joint fusion. All these changes produce the typical bamboo spine. Erosive changes may be seen in the symphysis pubis, the ischial tuberosities, and peripheral joints. Osteoporosis and atlantoaxial dislocation can occur. Management. The goals of treatment are to relieve pain and stiffness, maintain skeletal mobility, and prevent deformity. Non-pharmacological measures. Education of the patient about the disease. Regular daily back extension exercises, including a morning warm-up routine. Avoid prolonged periods of inactivity. Poor bed and chair posture must be avoided. Drug therapy. NSAIDs relieve the symptoms but do not alter the course of the disease. A long-acting NSAIDs at night is particularly helpful for marked morning stiffness. Anti-rheumatic drugs, sulfasalazine, methotrexate, or azathioprine may control peripheral arthritis but have little effect on spine inflammation. Anti-TNF agents, that is etanercept, infliximab, and adalimumab, have been shown to improve signs and symptoms of AS, including spinal mobility. Steroids. Local corticosteroid injections are helpful in persistent plantar fasciitis and enthesitis. Oral steroids are useful in acute uveitis but should otherwise be avoided. Surgery. Severe hip, knee, or shoulder restriction may require surgery. Total hip replacement, that is, total hip arthroplasty, cervical fusion for atlantoaxial subluxation, and wedge osteotomy for severe flexion deformities of the spine are the surgical procedures that may be required.